This is a video explaining how to perform a FacoGoniotomy. When performing a goniotomy, all three portions of the trabecular meshwork are excised. This exposes the collector channels for better aqueous humor drainage. Many procedures have been described, including KDB, GAT, trabectome, and goniotomy. In year 2020, the American Glaucoma Society exposed this mixed diagram to explain the different approach for glaucoma surgery. Take out traditional filtrating surgery, mixed bleb-forming implants, mixed inflow procedures like ECP, suprachoroidal mix, including this part, implants that goes in slim canal, and those procedures that dilate the canal. It leaves us with goniotomy and stays as a non-bleb canal mix procedure. This is a great option that does not leave an implant behind and is low cost effective. Regular phaco with intraocular lens implantation is performed. Avoid always hydration of the paracentesis for better visualization of the angle. Aspirate all the viscoelastic from the bag and constrict the pupil with carbachol. Fill the anterior chamber with cohesive viscoelastic. To start with goniotomy, turn the head of the patient away from the surgeon 35 degrees, and then turn the microscope towards the surgeon 35 degrees also. To prepare the cystotome, use the microscope and turn 90 degrees the tip of the 23 gauge needle with a flat forceps until you see the tip of the needle. This is a size and shape comparison of both cystotome and KDB. I am now placing the gonio lens for angle visualization. You can focus the distal limbus so when you place the lens visualization is better. There are three basic techniques to excise the trabecular meshwork. Inside out, where you start at one point and go superiorly, and then back to the same point and go inferiorly. In this case, ends do not meet. The outside in technique is when you start superiorly until one point and then inferiorly until the same point. In this case, the ends do meet. And last, mark and meet technique. This is my favorite. You start inferiorly to make a mark and then you enter superiorly to meet the end of the first mark. In this case, ends do meet also. I now enter the anterior chamber and I flip the cystotome to enter the trabecular meshwork to start the mark and meet technique. With constant pressure, I pass through it and then I enter the trabecular meshwork superiorly. See how the trabecular meshwork is excised until it meets the first mark. The trabecular meshwork is cut off completely from the Schlemm canal. At the end of the case, aspirate viscoelastic very well and finish the case. In this case, you can see blood in Schlemm canal before the procedure. This helps you identify the trabecular meshwork. I then enter the anterior chamber with the cystotome and I am making an inside-out technique. Heme reflux is very common. Aspirate and finish the case.